As you know that it is an organ which has a very important role in the metabolism, and it affects almost all the systems of the body. So here we have a middle-aged male who had an attack of stroke about 2 months back, and he had facial palsy and he was unable to lift his right forearm, and he was treated for stroke. He is also known, and he was not taking any medication for hypertension. During the examination, it was found that he has a swelling in the neck also, which was not investigated, neither it was seen by any clinician. So he has come to us to get the swelling evaluated. So in any swelling in the neck, first of all we want to confirm whether it is moving with deglutition or not. So if a swelling moves with deglutition, there are few differential diagnoses which we have to take into account. One is that it could be, if it's moving with deglutition, it can be a thyroid swelling, or it can be a thyroglossal cyst, or it could be some lymph nodes, or it can be bursitis. So these are four important differential diagnoses of any swelling which is moving with deglutition. Why it is moving with deglutition? Because it is attached through the thyroid, attached to the voice box,
trachea,
and when during deglutition the swelling is larynx as a whole moves, leading to the movement of the swelling. So now we'll ask him to move, swallow, thuk satake. When he's swallowing, we can see that the swelling is moving with deglutition. एक बार और कीजिए. So one thing is apparent in this case, that there is no previous history of patient does not belong to living in an endemic area. Neither he has any complaints regarding the swelling, and it is not a rapidly progressing swelling also, and he has no pressure symptoms, and is no evidence of or any history suggestive of metastasis from the swelling to other parts of the body. So with this brief history, following the stroke he had some facial palsy and he was unable to open his eyes, and there's some drooping of the oral right side of the oral cavity, and there is no now he is able to lift his arms also, but left side, right side is normal, left side is right side is affected and left side is having normal anatomy, and there is no pathology in that. So now we will just do the general examination. In general examination you have to see the vitals, especially in such patients you have to see the pulse, which is very important because it tells us whether there is tachycardia or not. And in this case it was 94 when we did the palpation. So there is tachycardia is there, and then pallor, icterus, etc. we have to see. And then eye signs, of course there are no eye signs. Now coming to exactly the swelling of the neck, we will just do the inspection, palpation of the swelling, and then we discuss the diagnosis and management. Now in the inspection you see that there is a swelling mainly starting from the midline to the right side. And thuk satakiye, scale leke aao, scale. Apparently the size is around 6 centimeters in the transverse direction and 2-3 centimeters in the vertical direction. The left side of the thyroid is not visible. So basically the swelling is confined to the isthmus and the right lobe. As you know that the thyroid swelling is butterfly in shape. So there is one half is having one wing of the butterfly, the other half is having another wing of the butterfly, and in the middle is the isthmus. So in this case, during deglutition and also on inspection, we can see that the swelling is confined to the central part and to the right side. Left side, it is not present. Now that is on inspection, and this swelling is moving with deglutition. There is no ulceration of the skin, there is no visible peristalsis, visible pulsations, and no scar mark over the swelling, and there are no skin changes. Now palpation, before that we like to see for local temperature. Local temperature is not raised and the swelling is non-tender. Now with that we'll confirm the diagnosis of inspection. We see the size of the swelling by measuring. This is the midpoint from where the swelling is arising, and this is the outermost level. So it is around 9 centimeters transversely, and it is around 4 centimeters in the vertical direction. So the size is 9 into 4 centimeters. On palpation, the classical method, there are 4 methods of palpation. One is the classical method, the second one is Leahy's method, the third is the Pizzolo's method, and third is Kreis Junior method. So Pizzolo's and Kreis Junior method will not be applicable in this case because that requires a special type of patient. In this case, only 2 methods are applicable. One is the classical method, and the other is Leahy's method. So first we will do the classical method. In the classical method, you have to stand behind the patient and start palpating from here. So we'll put both our hands here, and then we slide it on the lower side of the gland and come to the upper limit. Then we go towards medial side and go towards the isthmus. So now what we have done is we have seen the whole of the gland from the area where it starts and where it ends, and then we see the consistency, we see the nodularity, and we see the movement of the skin, and we'll ask him to deglutate whether it's moving on deglutation or not. So on palpation, it is around 7 centimeters and 3 centimeters, and it is only a single nodule is palpable. There is no other nodularity palpable, and it is non-tender. So on this side the gland is not palpable. So the left side, the gland is not palpable. It is only palpable starting from the mid part of the neck in front, and then towards the right side to the right side, and then coming back. So that is how we examine. Then in the front also we see whether consistency is firm inconsistency, it is not cystic, and it is non-tender, and there is only a single lobe which appears to be enlarged. This side is normal. Now in this case, Leahy's method also cannot be done because the other lobe is not palpable. If the other lobe was palpable, then we would have pushed the gland to the other side and made it more prominent and did that examination. So in this case, Leahy's method, if at all is possible, is only for this side because the other lobe is not palpable. So what we are doing is trying to push the gland, make it more prominent on the right side, and then we try to palpate it, and then we see the posterior part of the gland which is also palpable. So finally there is आई साइंस. ऊपर देखिए, नहीं आँख खोलिए. The eyes appear to be normal. There is no proptosis and there are no eye signs. None of them is present. Now just tremors. आगे करिए, हाथ सीधा करिए. This is to see for toxicity. Finger खोलिए, उंगली खोलिए,
सीधा करके रखिए,
सीधा करिए. You can see some minor tremors are there on both sides, but that could be just physiological, may not be pathological. And then finally we see the pedal edema. पैर दिखाइए. Presacral, there is some skin changes. there is no pedal edema. ठीक है, बस आ जाइए कपड़े only one half of the lobe with the isthmus is enlarged and it is a single lobe, then we call it a solitary nodule, and we have to see whether this solitary nodule is toxic or non-toxic. In this case, we have found that there is mild tremors and also there is some tachycardia, although there are no eye signs and there is no pedal edema. So partially clinically we can say that it can be a case of toxic nodule, but that has to be confirmed by blood investigations, which will tell us whether it is a toxic nodule or not. So in this case, blood investigations are still awaited. However, he has got an ultrasound done which shows that there is a solitary nodule and there are no foci of solid lesions in it, and it is suspicious to be a benign lesion. So to confirm whether this patient is having toxicity or not, we need to get the other investigations done, thyroid profile, TSH, T3, T4, and accordingly we will decide if it is a euthyroid or there is hypothyroid or hyperthyroid. So if it is a hyperthyroid gland, as is suggested by tachycardia and presence of tremors, so he needs to be put on anti-thyroid drugs for say 2 to 3 months, and then we see the result. After that, the swelling, if it persists, then we will have to do a FNAC, and FNAC has been done in this case, which is thyroids 2, which is suggestive of a benign lesion. So in this case, there is no hurry in going for any surgical intervention. Only after we have assured about the thyrotoxicosis, we have to decide about the further management. So possibly this patient can be treated conservatively by drugs to control the toxicity if at all it is present, and then since it is a single thyroid nodule, it is likely to change into a neoplastic process. So it is always safer to go and do a total thyroidectomy, and in this case, of course, if the other gland is normal, we will not leave it, we will remove it as a case of total thyroidectomy, and then hopefully the patient will be alright. So in this case, there are two things which need to be done. First is to confirm whether the patient is having toxicity or not, and if it is a toxic gland, then we have to start anti-thyroid drugs, and after the control of the toxicity, we can do, in this case, hemithyroidectomy would be sufficient because there is only one lobe which is affected and it is benign at present. So that is how we are going to manage this case. Thank you.